right, welcome back, everybody. Welcome to actually our last set of lectures. These are going to, as I mentioned in the last class, focus our attention on specific mental health disorders that have been defined by the DSM. But it's really important before we start this material to reiterate something that I talked about in the previous lecture. And that's the fact that even though we're going to be talking about specific mental health disorders, you have to remember that these particular terms and these particular labels are things that were created by clinical psychologists across the world to not necessarily stigmatize or unfairly label individuals who struggled with specific problems, but to give kind of a more coherent sense of some similar things that a multitude of people across the world are struggling with. And if you can kind of recognize that these categories are somewhat arbitrarily defined and there's lots of gray room in it, and it's also not an indictment on the person if they do happen to display the thoughts or behavioral patterns that qualify as disorders. I think we can go through this material in a much more sensitive and kind of aware way, where we don't have to kind of use these things as kind of barometers of people's sanity or something that we can maybe throw at people in terms of judgments, and instead just have a better sense of what clinical psychologists might encounter and why this particular area is of such interest to a huge percentage of people in the population. I guess I should also mention another thing that I talked about in the previous class, and that's the fact that when we cover these things, just by going over these things on the surface does not make you a clinical psychologist. So I don't want to hear about any of you diagnosing your family members or your friends with specific disorders. I certainly don't want to hear about any of you trying to treat family members or friends or other people that you might know after we've gone through this. This particular profession requires years and years of extensive training to be appropriately trained for this, but we all have to start kind of somewhere, and kind of getting a sense of what clinical psychology is about long before you would ever consider practicing this or diagnosing people with this is probably what we want to do in a class like this. So let's get started. In this lecture that's going to be about an hour long and the next lecture that's going to be about an hour long, what we're going to actually do is try to break down three kind of umbrella categories of disorders that are out there. We're going to focus our attention in this class and the end of this class on two different types of kind of umbrella disorders, what we call anxiety disorders and mood disorders. And in particular, we're going to break down certain diagnoses that clinicians might ascribe to people that do struggle with anxiety or mood issues. And then in the next class, we're going to not only kind of close out the talk on mood disorders, but we're also going to visit not necessarily a very common disorder, but one that's definitely been scrutinized and definitely appeared in television and movies and the news enough that it's worth mentioning, and it's a disorder called schizophrenia. We're going to really lay out what that particular disorder entails, some of the challenges that people with schizophrenia actually face, that people diagnosed, I guess, with schizophrenia face, and hopefully that again will give us a better understanding of these disorders if we do happen to encounter anybody along the way that's been diagnosed with these things, or if we do want to pursue a clinical degree somewhere down the line. So let's again start by talking about anxiety disorders. When we talk about anxiety disorders, I think it's first important to really highlight that there are a large number of different anxiety disorders that are out there, way more than what we actually have time to discuss in this particular class. But to kind of give people a sense of what anxiety disorders are like, I thought we'd cover four major things that, at least for the most part, are under the category of anxiety disorders. There is one sort of exception to this. It's a disorder called obsessive compulsive disorder, which historically has been defined as an anxiety disorder. But in the newest edition of the DSM, the fifth version of it, it's actually been reclassified as something called an impulse control disorder. But outside of obsessive compulsive disorder, the other three disorders that we're going to be looking at are very prominent, common types of anxiety disorders. If we want to understand what anxiety disorders are all about, well, going over those three can really help. So let's get started by looking at the one on the top. This first disorder that we're going to be focusing on again is called generalized anxiety disorder. The name really epitomizes what this disorder is like. In fact, when people think of anxiety disorders and think of a person that might be diagnosed with one, my guess is that their imagination probably brings them to somebody struggling with generalized anxiety disorder. For people who struggle with this, they have essentially pervasive free-floating anxiety that latches on to everything that they're encountering. They might have, say, a natural worry about school and friends, but that worry can also usually bleed into other random things like exercise and diet and whether or not they're getting enough sleep. But essentially, for people with generalized anxiety disorder, life is extremely stressful. There's no particular things that qualify somebody as having or being diagnosed with generalized anxiety disorders. It's not like if you worry X amount about school or something like that, you could qualify as being diagnosed with this. And it's kind of a little ambiguous moving target for this classification. But if somebody has a persistent amount of worry about a large number of things in their lives, a clinician might diagnose that person with generalized anxiety disorder. And it's really important to try to help individuals who struggle with this disorder as soon as possible, because oftentimes what starts out as tension and kind of a lot of stress can sometimes evolve into actual sleeplessness and something looking like kind of chaotic thinking. And this is because many people who struggle with prolonged bouts of generalized anxiety disorder tend to unfortunately have so much sleeplessness and such an inability to get a sound night's sleep that the brain starts to really kind of get discombobulated, and they start to really struggle with things like memory and attention and even motivation. So the way that this particular disorder manifests itself is somewhat dependent upon what period in time a person is really kind of struggling with this particular disorder. Again, I do feel like I need to reiterate that when somebody struggles with generalized anxiety disorder, it's not that they caught some random bug and it's something like the flu or the cold. This is something that's involved with thought patterns. And when clinicians define somebody as having this disorder, they're doing it because it allows clinicians to kind of have a way of communicating about individuals with similar problems. What we see is about 5 to 6% of the population is diagnosed by clinicians, at least in the United States, at some point in their life. And at any point in a person's life, about 2 to 3% of the time, these individuals are usually struggling with symptoms related to generalized anxiety disorder. That's a vast number of individuals within our population. And if we have roughly 320 million people within our population, and about 1 in 20 of them is struggling with this particular disorder, that means we're looking at, I believe it's roughly 60 million people in the United States are diagnosed with this disorder at some point in their life. We're looking at that population a little bit more closely. What we tend to see is clinicians diagnose certain groups within the population much more than others. We know that women are diagnosed about 2 to 3 times more often than men, and people that come from lower income households and have marital issues also tend to be diagnosed significantly more often than those that don't fit into those categories. There is, however, a lot of questions about why this is the case. Some people argue that maybe these particular groups are more inclined to reacting to stress in a manner that gets them to a diagnosis of this disorder. Others have argued that maybe it's more about sensitivity of clinicians, where if they see somebody coming in with some stress and they happen to fit into these categories, they might be diagnosed with this disorder. Where if they see somebody coming from a different collection of categories, maybe an upper class male, they might get a completely different diagnosis or might not get diagnosed at all, even though they're manifesting the exact same symptoms or reporting the exact same things. But regardless of what the differences are, being mindful of the ratios is something that we probably want to be mindful of, just so we kind of have that under our belt and can appreciate some of the other things that clinicians are looking for when trying to better understand these types of disorders. If we're looking at what's usually done to treat this disorder, what we tend to see is this one is kind of a lifelong thing. Usually, for people struggling with generalized anxiety disorder, they're not even diagnosed with this disorder unless they've had symptoms for a number of months. And for many individuals who struggle with this, it's kind of something that needs to be consistently addressed throughout the lifetime of these individuals. Some individuals might have kind of short bouts of generalized anxiety disorder, but oftentimes people who struggle with it tend to need to utilize some type of antidepressant or some type of relaxation training to really balance them and kind of make them a little bit more capable of functioning in the day to day, at least to the level that they would like to function at. This is, however, a particular disorder that tends to, as I mentioned, be fairly persistent in the lives of these individuals. So, kind of sensitivity to where somebody's at the time, whether or not somebody's kind of monitoring their anxiety, is a concern for many clinicians trying to help individuals that they've labeled as struggling with this particular disorder. But again, this disorder is usually the typical one that people think of when they think of anxiety disorders. There are, however, some other ones that maybe on the surface look by name very similar, but have very different elements to them. In fact, the one we're going to be covering next definitely qualifies as such. The disorder we're going to be talking about now is the second one that was on that list earlier, called panic disorder. Generalized anxiety disorder and panic disorder sort of sound similar, but the symptoms related to panic disorder and a lot of other characteristics linked to it are substantially different from generalized anxiety disorder. With panic disorder, what we see is individuals who tend to go about their lives without displaying on a day-to-day basis large amounts of stress. We don't see the sleeplessness issues. We don't see individuals that are struggling with a multitude of different problems. But for people with panic disorder, what really highlights the reason why they've been qualified as struggling with this disorder is that they have a repeated number of these things called panic attacks, where essentially their fight or flight system, something that we call the sympathetic nervous system, gets overpowered and essentially it goes into overdrive and causes a huge amount of fear, even though there's nothing that's necessarily triggering these panic reactions. And people struggling with these, what we call panic attacks, often report a variety of different symptoms. Now, what's really kind of interesting with this is it does tend to vary from person to person. Some people report feeling like they're choking, others feel like they just can't control their bodies, others feel like their heart's going to explode. There's a variety of different ways that these panic attacks can manifest themselves, but for people who are given the diagnosis of panic disorder, they have to have a large number of these panic attacks within a short period of time, and most importantly, these panic attacks, they should be coming out of nowhere. Now, it's really important to note here that a panic attack itself does not qualify as a diagnosis of panic disorder. Many individuals might have minor or even major panic attacks due to certain circumstances that arise in life. If you are really aspiring to accomplish something and something very tragic in your life happens that kind of blunts that, experience of a panic attack might indeed occur. In fact, I'm guessing a large percentage of the population sitting here right now listening to this lecture has had some type of panic attack in their lives. But if you experience a vast number of these and they're coming from nowhere, that's when you might be diagnosed with panic disorder. And a decent chunk of the population is actually diagnosed with this disorder because they have that problem. Roughly 5% of the population is diagnosed with panic disorder at some point in their life. And if we're looking for who's diagnosed with this, a lot of those numbers that we talked about before with respect to generalized anxiety disorder don't pan out with panic disorder. Instead, what we tend to see with panic disorder is there's not specific groups that we're looking at that has a higher proclivity of being diagnosed with this, but there do seem to be genetic markers and family members that seem to be kind of good indicators of who's likely to develop this disorder and who's not. And this is something that many people have been attending to, sorry, because there is a belief by many people studying panic disorder that if you can catch it early enough, this can really help stave off some other problems that are often tied to panic disorder. Because even though by definition panic disorder tends to be linked to panic attacks that are coming from nowhere, Because our minds are programmed to try to find connections to things, many people who are diagnosed with panic disorder eventually start to associate certain things with the panic attacks they're experiencing. When people start to develop phobias of going outside, others develop phobias of specific areas or of social interactions. There's lots of different types of concerns that do start to develop in individuals with panic attacks because there's this attempt, this natural inclination to try to figure out what the source of these things are. So oftentimes what clinicians try to do is try to find ways to lessen the intensity and the frequency of these panic attacks. Unfortunately, with this disorder, even if we can really pinpoint that somebody's struggling with it, treating it is sometimes a challenge. There have been some drugs that have proven to actually help with the magnitude of the panic attacks that people are having, but many individuals who struggle with panic disorder aren't necessarily big fans of taking these drugs because, as I mentioned, they're not really inundated with anxiety throughout their days. It's just something that tends to pop up on occasion. And these drugs don't just work only with the panic attacks. They shift the individual throughout the day, regardless of whether or not they're experiencing a panic attack at that moment. Moreover, lots of people struggling with panic disorder worry about becoming addicted to these drugs or kind of feeling like they need to rely on them on a regular basis throughout vast majorities of their lives. And oddly enough, what we also see in lots of research is that these drugs don't always work with lessening the number of panic attacks that people have. This is why sometimes clinicians have tried to rely on behavioral treatments to help individuals with this disorder. Fortunately, much like antidepressants, these behavioral approaches seem to work a little bit with the strength of panic attacks, but aren't necessarily that good in reducing the number of panic attacks people have. And in fact, some studies have even shown that they could have a reverse effect where they cause more panic attacks when people start trying to attend to the things that are kind of indicating a panic attack is underway. Fortunately, if we're looking for silver linings with this disorder, what we tend to see is lots of people who struggle with panic disorder do see kind of a light at the end of the tunnel. Usually there's a peak in the development of this disorder for people who start having massive numbers of panic attacks, and then that peak starts to abate, and over time, the panic attacks become less robust and less frequent. But getting to that end can definitely sometimes be a challenge for people who struggle with panic disorder. I do want to now turn our attention to that thing that I mentioned earlier, the strong fears of things that people sometimes develop, because this actually references another type of disorder that seems, again, on the surface, very similar to panic disorder. This disorder we're going to be talking about now is something that we call phobias. Phobias are essentially profound fear reactions, but not to nothing in particular like we saw with panic disorder, but instead to something very specific. What we see with phobias is that they are very commonly diagnosed in people in the United States. Almost 9% of the population is diagnosed with this at some point in their life. Actually, I think we're at almost 10% if we look at some point in a lifetime. But what we also see with phobias is that they do have lots of comorbidity with a lot of other anxiety disorders that we've talked about. The overlap between generalized anxiety disorder and phobias is very strong. The overlap between panic disorder and phobias is very strong. And in fact, the overlap between phobias and what we're going to be talking about next, even though it's, again, not technically an anxiety disorder, something called obsessive compulsive disorder, is also very strong. Essentially, phobias are something that's a specific disorder, or specific qualified as a specific disorder. And if you're displaying symptoms, a clinician will give you this disorder, but it's something that's often tethered to a lot of other mental health issues that these people might be struggling with. If we're looking for common phobias, what we tend to see is some of the ones that we've mentioned previously, usually the ones that people are diagnosed with these days. Social phobia, or sometimes it's called social anxiety disorder, is found in approximately 4% of the population. But I do want to highlight here when we're talking about social phobias, we are talking about a clinical definition of this, not just something that somebody kind of off the cuff mentions. I've heard many students over the last couple years suddenly indicating that they really struggle with social anxiety disorder because they don't like going to parties or they really hate talking on the phone to people. This is not what clinicians define as social phobia or social anxiety disorder. For people that are diagnosed with this, it's terrifying for them to be exposed to social interactions. You can be introverted. That's a totally common thing. But to qualify as having social phobia, it has to be something where social interactions are overwhelming to you to the point where you can't handle yourself when you're in the presence of others. And nonetheless, even though that's a pretty high bar, unfortunately, a big chunk of the population does struggle with this. And for them, day-to-day social interactions can be extremely daunting. This particular disorder is also often paired with another very common disorder that's found with phobias called agoraphobia, where people feel lots of fear and often have these fight or flight reactions when they're in open or exposed places. It's not that social phobia and agoraphobia have to go hand in hand for everybody, but there is, as I mentioned before, lots of comorbidity with these two disorders or these two types of phobias that are out there. There's also lots of specific phobias that people can develop, and this involves things like fears of spiders, fears of heights, fears of being in enclosed spaces. There's a wide range of different phobias that people can potentially be diagnosed with, and many individuals who are diagnosed with one phobia could potentially have multiple phobias that they've developed. But if we're looking kind of for estimates as to where these things are coming from, we do see some very small genetic links. We'll talk about that in the next one, next slide. But what we tend to see again is that women, for some inexplicable reason, are diagnosed about 2 to 4 times as much as men, depending upon the study that we're looking at. If we're looking for why that's the case, the jury is still out on this. It might again be just oversensitivity of the clinical world, where if women come in with a set of problems compared to men or any other gender come in with these sets of problems, maybe the women are twice as likely to be kind of diagnosed with these issues in these labs or in these clinics. It could be just about how people are kind of taught to react to stress, or most likely probably a combination of a multitude of different things. But statistically, since we're looking at research-based information, this is something that we do always want to lay out. If we're looking for where this is coming from, though, what we do see is that there is, as I mentioned in the last slide, some links to genes and the chances of developing phobias at some point in life. But what we tend to see with this one, as opposed to panic disorder, is that those genes are more indicators of kind of a propensity to develop phobias. What we tend to see is if you have that propensity, you also tend to need some type of catalyst, some type of event or thought pattern that triggers this phobia. It could be something related specifically to the thing that you develop a phobia of, or it could just be an undue amount of stress and problems in life that eventually evolve into the development of some particular type of phobia. But for people who struggle with this, as I mentioned, it's something that becomes extremely debilitating. Phobias are not just you not liking things. For me, I personally do not like needles. I get a little squeamish every time I have blood drawn or I get injections. But here's the catch. I don't avoid hospitals because of my fear of needles. I don't have tons of dreams about being exposed to needles. I don't do things to go out of my way to avoid the potential of encountering needles at some point in the day. Therefore, even though I might have a pretty strong irrational fear of needles, I don't quite get to that qualification of being diagnosed with a phobia. And that high bar is extremely high, and it does cause many people who say they have an irrational fear of things not quite get past the threshold of being diagnosed with the disorder. But there's still a large percentage of the population that does get past that threshold. And I also want us to understand that, remember that this threshold is kind of arbitrarily defined by clinical psychologists. It's not that my squeamishness about needles is necessarily a perfectly common thing that everybody has. It's definitely something that's quirky to me. And pretty much everybody else has something that they're quirky, scared about. And that's typically just the norm for the population. But what we tend to do in clinical psych is, again, draw these arbitrary lines and say, look, if somebody gets past this point, this is when it qualifies as a diagnosable disorder. And we can conduct studies on it, collect statistics on it, so we can really understand where it's coming from and try to help people who struggle with these problems where it does start to eat away at their lives. And when we look at phobias, one of the nice things to note here is that if a phobia is identified in individuals, a large number of different treatment approaches have been established and proven time and time again to be very effective. One of the first techniques that's proven to be extremely effective in treating phobias is behavioral interventions. There's things called exposure therapies that work really well. If we were taking this as an in-person class, in the last class when we talked about clinical treatments, I would have actually shown you about a 10-minute clip of a therapist using exposure therapy to help a young woman overcome her fear of snakes. And this video actually shows that within a few hours, the amount of stress reaction this woman's displaying to snakes dramatically drops. It's not that she's 100% better by the end of the 3-hour session, but the, the effects are very noticeable. And this is true for most individuals that are willing to seek therapy for this disorder. Interventions like behavioral therapy or social cognitive approaches have proven time and time again across a variety of different settings and across a variety of different types of phobias to be extremely effective techniques, especially if the person encountering them is willing to go through it, willing to go through the challenges so they can overcome the kind of day-to-day struggles that they have with these phobias. There are, however, some individuals that are not necessarily open to trying to face their phobias head on, and in those cases, pharmacological treatments have proven to be somewhat effective. Tranquilizer, antidepressant drugs, things that kind of slow down the nervous system have proven, maybe not quite as well as behavioral therapy or social cognitive therapy, but they have nonetheless proven to be somewhat effective for individuals. And for some people, they're a first step down the path of trying to kind of overcome the phobia. But regardless of what path somebody takes to overcome it, if people do try to get help for phobias, which is a big if, because this is a challenge, there is often a very bright light at the end of these tunnels when people do have these irrational fears that are really eating away at their lives. Last disorder that we're going to be talking about in this anxiety disorder umbrella again, which actually technically is not an anxiety disorder anymore, is something called obsessive compulsive disorder. Again, historically, this disorder up to the newest edition of the DSM was considered an anxiety disorder, and that's because at the heart of it are these things that we call obsessions. But the other end of this, which is why it was recategorized, are these things called compulsions, these irresistible acts that people act on because of the obsessions that they have in their minds. Okay, since most clinical psychologists do focus on actions over things going on when trying to define disorders, the OCD has been moved into the newest category of what we call impulse control disorders. So this kind of relates to other impulsive behaviors that people have that can relate to kind of addictive behaviors or other things that kind of all have similarity in the fact that these people are doing things that they can't control and they don't want to do them, but they feel like they have to do them nonetheless. For this particular disorder, it's kind of extremely uncommon in comparison to a lot of the other ones that we've looked at. What we tend to see for people with this disorder is that this disorder really does eat away at their daily functioning, but it's not necessarily a large percentage of the population that struggles with this. For people who are defined as having obsessive compulsive disorder, the obsessions and the compulsions that eventually come from them uh, kind of eat away at their daily functioning in a way that they don't actually want them to. And this kind of definition of it is something that's really worth mentioning because, again, much like phobias, there has been, for some inexplicable reason, a large number of people recently in our culture that have started to define themselves as having obsessive compulsive disorder or kind of being diagnosed with it. In reality, that they're just kind of organized or meticulous. I've heard many students say, oh yeah, I like to have my notes organized in this way because I'm totally OCD. And that is not what obsessive compulsive disorder is all about. And for people who are diagnosed with this, they're not perfectionists. In fact, there is a specific disorder that is related to it called obsessive compulsive personality disorder, which is really about kind of an obsession with perfection across every aspect of life. It's not that. This is not that. It's more about kind of something that kind of gets in the heads of these individuals, and they feel like they have to act on these things even though they recognize it's irrational. And it's oftentimes, and this is a big thing that kind of separates those that love to have their notebooks organized. For people who struggle with this, that they realize not only do they not want to do this, but it's not helpful to them. It's oftentimes destructive for them to constantly be acting on these compulsions, but they act on them nonetheless. That's why only about 1.6% of the population is defined as having this, because even though lots of people can self-diagnose themselves with them, it does not necessarily happen that commonly. If we're looking for where this is coming from, there have been some studies to suggest that there are some genetic inclinations for individuals, especially if symptoms of this are kind of presenting earlier in life. But outside of that, it's somewhat random. There's some research that suggests that people who are slightly above average in intelligence and defined as hard-working perfectionists at young ages could have a proclivity for developing symptoms of this, but the effect sizes of these things are fairly minimal. So what we tend to see with this is that it seems to be a somewhat random disorder that doesn't hit many individuals, but when it does, it can really eat away at the lives of these individuals. Because even though on the surface they might look like they're highly functional, in the background, in their heads, are lots of worries that can definitely eat away at their daily functioning. Again, if we were taking this class in person, I'd be showing you a video right now of a gentleman describing some of the thoughts going on in his head at any given moment and how they do occupy a large amount of his daily activities. We don't obviously have the ability to do that, but just know he would epitomize the frustration that many people struggling with symptoms that eventually qualify them as being diagnosed with having this disorder struggle with. And to treat these individuals, oftentimes behavioral treatments and cognitive treatments are fortunately very effective again. One of the classic approaches that's been used for this disorder is something called exposure therapy, where a person is essentially not allowed to act on their obsessions, not allowed to commit their compulsions, and just see how things play out over time. Oftentimes, obsessive compulsive disorder is tied to these things called catastrophic fears, where there's this belief that if you don't get to check something or clean something or collect something, that something really bad is going to happen. And over time, if there isn't the ability to act on these obsessions and nothing horrible ends up happening, then usually the obsessions start to abate to an extent. Now, there does need to be an extended amount of involvement, and there can definitely be pushback, and it can be very, very scary for people who struggle with this disorder when they are going through this exposure therapy. But when it's done correctly and in an ethical way, it can actually be very helpful to individuals who struggle with this particular disorder. Another thing that's worth noting with obsessive compulsive disorder is that many people do tend to report an abatement of their symptoms after they've peaked, just naturally over time. And some clinicians have suggested that this might be a byproduct of them just simply kind of doing their own exposure therapies unintentionally some of the time. But whatever the reasoning is, we do see that this disorder is not one that tends to be lifelong for most people struggling with this, even though there are some people that can have this persist throughout a large portion of their lives. But when it hits these individuals, the symptoms are very powerful, and they can definitely affect a person's life, even if most people can't see the impacts of this disorder on the surface. And that's going to wrap up our discussion, again, of what clinicians call anxiety disorders. Obviously, hopefully now that we've gone through this, there are lots of differences between the different types of anxiety disorders that are out there. There's even more than the ones that we've covered in this class. Now that you have hopefully a better sense of some of the symptoms related to some of the common ones, some of the treatments related to them, you might be a little bit more aware of these disorders if somebody, again, tells you that they've been diagnosed with these things, or you potentially recognize symptoms within yourself or others that could be linked to these disorders. I need to stress again, do not be a clinician after this. Do not go and diagnose your roommate as having this disorder or that disorder just because we've covered this. This is all about being more aware and sensitive to these topics, nothing more. Let's move on to the next topic now. All right, now the next set of disorders that we're going to be talking about in this lecture are what we call mood disorders. But it's probably important to note that we're only going to be focusing on one particular mood disorder in this lecture, one of the most common disorders that's actually out there, and one that really does epitomize mood disorder, something called depression. But actually, much like anxiety disorders, there's a wide range and number of different mood disorders that are out there. So in our next class, when we start off, we're going to actually be breaking down some additional mood disorders that somewhat relate to depression, but definitely have their own nuances and statistics to them. But I do like to close this class out by talking about depression because it's a really important topic to discuss, not only in clinical psych classes in general, but in this class in particular. What is depression? Why is it something that we want to talk about in an intro class, even if many of you are not aspiring to get into clinical psychology? Because first off, we should acknowledge that depression is a very wide-ranging definition. Clinicians tend to be looking for negative mood and lethargic behavior, but in terms of what qualifies as somebody being diagnosed with depression, can be a lot of different things. People who lose interest in stuff and feel lots of guilt, people who are more irritable or just don't feel quite themselves can all be diagnosed with depression. Another thing that often gets tied into depression is this idea that suicidal ideation can sometimes pop up, and it indeed can pop up in individuals diagnosed with depression. It's really important in a class like this to tether suicidal ideation out from or away from depression, because many individuals unfortunately don't seek help, don't seek therapy when they have symptoms that definitely qualify as depression, simply because they come to the conclusion that since they're not thinking about suicide, or that it's just kind of a thing in the back of their minds, they couldn't possibly qualify as being diagnosed with depression. It's definitely not the case. And in fact, depression goes into so many different things that it also tends to be tied into other cognitive functions. So what we tend to see is people with memory issues, people with attention issues potentially have symptoms that could be linked to depression, and sleep issues are often tied to depression as well. But sleep issues is a very broad term where some people struggling with depression get very little sleep, while others can get a vast number of hours of sleep almost every single night because of the symptoms with depression that they're struggling with. It's, again, a pretty wide-ranging thing, which means that it does grab a big chunk of the population with mental health issues. In fact, about 15 to 20% of the population is actually diagnosed with depression at some point in their life, at least in the United States. And this number has been holding fairly firm for a large number of years. If we're looking for groups that are more likely to be diagnosed with depression, again, we see women being much more likely to be diagnosed with depression than men. I know it seems like we're probably picking on women at this point. I promise with other disorders, we're going to see men being more likely to be diagnosed than women. In fact, one particular disorder we're going to be talking about in sections, substance abuse, we see a huge difference between men and women in terms of the likelihood of being diagnosed with this, with men really leading the charge on that particular disorder. And again, why women are diagnosed twice as much is tough to really figure out. It's not a lot of people that are that are considering this kind of a genetic thing, and more there's a lot of people that think that there's a lot of societal reasons and stereotypical reasons that maybe cause women to kind of manifest symptoms that are more closely linked to depression, and cause clinicians to just err on the side of diagnosing women with depression more often than they do men. Uh, but regardless of what the combination of sources are for this, statistically, in the population, a huge percentage of women are diagnosed with depression in comparison to men. We're talking almost 25% of women being diagnosed with depression at some point in their life. That's a big percentage. 25%, if we're looking at our class of 400 students, means about 100 people within the class or 20, sorry, I have to correct myself. If we're talking about 15%, it means roughly, what is that, 80, 90 people within the class are going to be diagnosed with depression. But since we have a much higher ratio of women to men in the class, uh, yes, obviously we don't want to just speak of these binary terms, but if just trying to kind of focus on specific genders that this research relates to, um, we see that roughly probably 100 people in this class are probably going to be diagnosed with depression at some point in our lives. So if we're looking for kind of what happens when depression emerges, we want to understand kind of all the nuances to it. And what we tend to see for people diagnosed with depression is it not only changes behaviors and cognitions, but it also tends to change things that are happening within the brain. What we see in numerous studies is that people who are diagnosed with more robust symptoms of depression tend to also have neurotransmitter levels, in particular serotonin levels, much lower in certain areas of the brain. And again, if we remember back to neurotransmitters, neurotransmitters are linked to neural functioning. So essentially, if you have lower levels of serotonin going on, you have less activity in certain areas of your brain. That's why many treatments actually relate to these particular drugs or these particular neurotransmitters. Sorry for that noise in the background. I just realized my son was kind of chattering. If any of you heard it, I apologize. Going back to this though, obviously, neurotransmitter level production is something that we've attended to a lot lately, but there's other big things that are also tied to the emergence of depression that are worth noting. One thing that we see is that usually huge stressful events can take somebody who already has a proclivity for developing symptoms of depression or maybe have developed minor symptoms of depression to get past that threshold where they are now diagnosed with depression. And there are other things linked to this that are worth noting, like a lack of exercise has been linked to higher rates of depression, poor diet, poor sleep hygiene. All of these things tend to either be the triggers of bouts of depression or take somebody who already is susceptible to struggling with depression past that threshold and get them to be qualified as struggling with depression. And this is why talking about it in a class like this is really important. I know many of you in this class are going through lots of stress. I know also many of you in this class have seen some dramatic shifts in your life over the last couple months since you got into Berkeley. I know oftentimes Berkeley students have just horrific sleep patterns where you maybe stay up until 2 or 3 in the morning and maybe sometimes get up at 7 or 8 in the morning and other times get up at noon, and that irregular sleep pattern can just wreak havoc on your mental health. I also know that many of you choose diets that are, well, according to your parents, abhorrent, where they see you eating things that can dramatically shift your abilities to kind of stave off certain things that could trigger depression. We also see a change, dramatic change in people's activity levels when they get into college. Now, this is also why when we're talking about how to help people with depression, one of the first things that's often done when people display at least moderate to mild symptoms of depression, we have people tend to correct some of the things that might be exacerbating their symptoms in the first place. Regular sleep, exercise, better diet, just better self-care is something that's often prescribed to a lot of individuals, and it's prescribed because it's a very effective tool. If that's not sufficient, there are lots of drugs that can try to restructure the brain, get certain cells to be more active, which increases levels of serotonin. that have proven to be extremely effective. And if that's not sufficient, psychotherapies do work really well as well. And in fact, almost every psychotherapy has shown almost a 50% effectiveness rate over the course of a year when people do start to seek therapy. The psychodynamic approach, the Freudian approach, is one small exception to this, where it doesn't usually work very well, at least in the short run. But people who abide by this approach would probably contend that this is simply because this takes time. If you want psychoanalysis to work or the psychodynamic approach to work, you need to give the approach time. I don't want to get into that debate right now, but what I do want us to understand with these slides and with this information is that depression hits a large number of us, a big percentage of the population. It does not mean, though, that this is something that you have to struggle with alone. There's lots of different therapies that are out there, lots of interventions that are out there. And if you know somebody who's struggling with these things, keep in mind that it's not that something broke, that something's just wrong with these individuals for their lives. It's just they've struggled with symptoms enough that's put them past the threshold to be defined as having depression. And intervention could really help these individuals, and sensitivity to the topic, not stigmatizing these individuals or treating them in unfair ways, can also do wonders for the mental health of these individuals. And also, again, lots of you are in a critical moment in your life where depression is very likely to come on. And if you've got a proclivity for it, this is usually one of the times where people see emergence of symptoms related to depression really start to pick up. And being mindful of that also is something I really want you to be able to do in a class like this. This is going to be where we're going to close out. I know that seemed probably more like a public service announcement at the end there than a class, but I really always feel like I have to do that because my role as an instructor is not only just give you the general information about this stuff, but to really allow you to relate some of the things that we're covering to your lives. This is also what we're going to do when we continue on with talking about other mood disorders in the next class, and it's also going to be something we're going to be doing when we talk about a really misunderstood and stigmatized disorder in what we call schizophrenia. But for now, we're going to close out, and I will hopefully see most of you in our very last lecture. I do want to apologize for the two kids that I've had running in and screaming in the background. Hopefully I was able to edit out their yells, but I guess I can't guarantee that. So I promise I'll do my best to kind of get them out of the room for our very last lecture. Until then, I hope you're all doing well, and I'll see you soon.